Welcome and good evening to everyone joining us for this session of Ask the Faculty featuring Accelero Health Partners. My name is Joe Tamara. I'm the General Manager of Accelero Health Partners, and I will be serving as your moderator for this evening's broadcast. Accelero Health Partners is the consulting division of Zimmer Biomet, and we've worked with hospitals both in the United States and internationally, as well as surgeons, helping to improve and create value in musculoskeletal care, in joint replacement, hip fracture care, as well as spine care. It's my pleasure to be the moderator for tonight's broadcast. This Ask the Faculty series is an important tool for you because it informs you and allows us to inform you about exciting new technologies and also industry trends that are impacting our surgeons and their practices, but more importantly, their patients' lives. Tonight, we are very fortunate to have with us two very prestigious orthopedic surgeons to speak on the behalf of Accelero Health Partners. First, I'd like to introduce Dr. Mark Hart Span. Dr. Hart Span is a medical director and founder of the Hart Span Center for Hip and Knee Replacement. He also serves as the director of the prestigious Joint Replacement Service at Hackensack University Medical Center and is also the director of Bone and Joint Center at Holy Name Medical Center. Dr. Hart Span lectures nationally and internationally, has authored many articles and book chapters on topics relating to total hip and knee replacement, and his specific focus is on outpatient joint replacement. We'll hear a little bit later in the broadcast from Dr. Hart Span specifically on outpatient joint replacement. Also joining us tonight is Dr. Tomlison Eggrow. Dr. Tomlison Eggrow is a partner in Tri-Rivers Surgical Associates, and he's the director of the joint replacement program at Butler Memorial Health System near Pittsburgh, Pennsylvania. His practice focuses on surgery of the knee and hip to include total knee arthroplasty, total hip arthroplasty, and also revision arthroplasty. Dr. Tomlison Eggrow really has specialized in the past few years of working with his hospital on the development of the joint replacement program, especially as the hospital enters into the new CJR program. And later on in the broadcast, we'll talk to Dr. Tomlison Eggrow specifically about that. Please remember that this is an interactive broadcast, and you can submit your questions at any time by clicking on the green Q&A button in the lower left-hand corner of your screen. We will address these questions at the end of the presentation. In the next 2 years, based upon what's going on in healthcare industry trends for orthopedics, two areas rise to the top. Number one, more and more payers are looking at bundled payment as a payment model for joint replacement care. And then secondly, there's increasingly more conversations about outpatient joint replacement on the right patient population. We're fortunate to have two surgeons here that have expertise in these areas. Now, even though we think about those areas as separate and people discuss them as separate, the way we like to think about them is really a continuum of joint replacement care. We know that there will be certain patients out there that will need to have a 3-day hospital stay and have care afterwards in a skilled nursing facility. We know there's patients that will have a 2-day pathway and then get discharged to home. We also know there will be a population of patients that will have a joint replacement done as an outpatient, whether that's a 24-hour stay in a hospital or day surgery discharged to home. The key is going to be in all of those areas to be able to predict each of those patient populations with some amount of accuracy in order to put the patient in the best care situation at the best cost. In other words, the definition of value. And then probably the other area that links this together is that we have to think about both the inpatient care and outpatient care in the realm of the entire episode of care. All right, so let's talk first about this bundled payment concept. Joint replacement is a target for bundled payment quite simply because if you look at 1 million joint replacements being performed and you look at an average episode of care cost of somewhere between $22,000 and $23,000, you really get to a total cost of about $22 to $23 billion to care for those patients. Now, this concept of looking at the episode of care is not new. About 10 years ago, there was data looked at in this article that showed large variation between the cost that Medicare was paying out for total hip replacement patients. You can see on the lower decile, that cost was $17,784, and on the high side, it's $24,693. A lot of variation in post-discharge care and readmissions. This data was from 10 years ago. Okay, so again, people have recognized that there's variation in that total cost of care. More recently, Blue Cross Blue Shield put out a payment and showed their payments from 2010 to 2013. And one of the key areas that you see is that in those red bubbles, that means the variation in each market of what they're paying out is somewhere around $19,000, the variation of care from 30 days pre-surgery to 90 days post-surgery. If we look just at a few examples, you see in Dallas as an example, you can see that the minimum cost is $26,000. The highest cost of what Blue Cross is paying out in that market is nearly $65,000. You see that same trend in Chicago for total hips, and in Dallas and Chicago both for total knees and in both areas. So you can tell there's a lot of variability in costs, so this idea of thinking about ways to reduce the payment, okay, for total joint replacement is not new. It's something that people have been looking at. Now, most payers, including Medicare, have approached this early on in really a voluntary type concept. There's been numerous bundle payment programs, both from Medicare and non-Medicare, okay, that have focused on these areas. The issue that we've run into, and I'll use the bundle payment for care improvement as an example of it, and this data is from May 2015. By now, everybody that's in the bundle payment for care improvement, BPCI, has had to commit whether they're in phase 2. Remember, phase 1 of the program is the patient essentially, or the hospital essentially, getting data on their patients. Phase 2 means that they truly entered into the bundle payment market. Okay, interestingly, what you see is a lot of people got data. Very few people signed up for the voluntary program. Okay, in fact, only 173 hospitals committed to the phase 2 Model 2 bundle payment. So what does that tell you? Well, people aren't going to do this voluntarily. So the next iteration is what we're dealing with today, which is a comprehensive care for joint replacement. We could spend the entire web seminar, the audio cast today, talking about this. Instead, I'm going to really spend time on what you can do about it. I'll talk a little bit about some of the rules and regulations. Again, these just came out in final over about 2 or 3 days ago. In this program, 67 metropolitan statistical areas, okay, will basically, it'll be required that it's mandatory bundled payment. Okay, it's a Medicare program looking at total hips, total knees, as well as partial hip replacements. Okay, and in those 67 areas, it's estimated that that will cover somewhere around 25% of the hospital. So whereas people weren't signing up for the bundle payment voluntarily, now you're in a situation that it becomes mandatory. The basic gist of it, without getting into too much details, is that the hospital, there will be an average regional cost, okay, that Medicare is paying out for total hip and total knee replacement patients, okay, in that market. So as an example, let's say that it's $25,000. Okay, in that price range, there will be rewards, okay, and also penalties. So let's look at the penalties first. So for instance, if your cost in the region is $25,000, okay, in year 1, it doesn't matter, there's no penalties for your particular hospital. In year 2, okay, if you are 5% above that baseline cost, $26,250, okay, then you're going to need to pay a penalty back on each of those cases that you're above that amount. Okay, so again, above that $25,000 to $26,550, so $1,250 on every case, okay, within your Medicare population of total hips, total knees, partial hip replacements. Okay, in year 3 then, that goes to a 10% limit, and in year 4 it goes up to 20%. So if in year 4 your cost is still $30,000 and your market is $25,000, that means you're paying a $5,000 penalty on every total joint replacement patient in your hospital. Now, on the other side of it, there's rewards that are put in place. Okay, same concept, year 1 and 2, okay, if you're 5% below, you can get paid a reward, okay, on that difference between 5% below and the base for years 1 and 2. Okay, years 3, it goes to a 10% reward. In year 4 to 5, up to a 20%. So again, that $5,000 swing, okay, times every patient that you do. So again, the stakes are fairly high. If you do the math, $5,000 over 500 cases, you're up to $2.5 million swing, either on the positive or negative, okay, that's out there. Now, the last part on kind of the rules of this is that the physicians, surgeons, can be collaborators. the hospital has to have 50% of that reward risk to them personally. Of the remaining 25%, they can push that out in both the risk and the reward category, okay, to surgeons, to skilled nursing facilities, home care. Okay, and of that 50% they push out, only 25% can go to one group or provider, i.e. a group of surgeons. Okay, so obviously when we talk about opportunities in the upcoming year for surgeons, this is big in those markets that have CCJR. All right, so now what I'd like to do, instead of going through all the rules of CCJR, is really talk in a case study with Dr. Tomlison Eggrow about where that opportunity is. So first of all, Accelero has worked with hospitals, really throughout the nation in a joint advantage program, working with all of those concepts in total joint replacement. Now, when we get to this CCJR, or the bundle payment, we think there are really 5 keys: infrastructure, data, benchmark metrics, decreasing variability, and then finally controlling post-discharge care. So let's talk about each of those. So Dr. Tomlison Eggrow, this article came out and it's very timely because there was a survey about the bundle payment method to the AAHKS membership, and a couple things came out of that. One is that most surgeons felt that bundle payment was probably the best way to deal with this concept of improving quality and reducing cost, but there were 2 concerns, right? One was disincentives on high-risk patients, and then others were concerned about the revenue sharing. So, based on the article, do you want to comment on, really what that has meant to you as you start working with your hospital in this CCJR model?
Sure. So I think it was a good article, and I think it was actually fairly reasonable. If you're going to try to both increase quality and decrease cost at the same time, which might seem to be opposing goals from a business point of view, then you needed to bundle, you needed to bring to the table the primary people who would be involved in driving forth change for the positive. Right. From a physician point of view, there's no disincentive to patient care or treatment, but you could argue there's a disincentive to surgical intervention. The flip side of that would be, is this an incentive to even greater maximization of patient optimization perioperatively?
Yep. So your hospital that you work with, Butler Memorial Hospital, is in one of the CJR areas, okay? So now, starting April, it's mandatory bundle payment. So in those 5 areas, let's start with infrastructure. Now, fortunately, you've done a lot of work in the service line having this type of infrastructure in place, which is a real good then transition to use that infrastructure as you get into this broader episode of care. So do you want to talk about the infrastructure that's in place at the hospital now?
Sure. We implemented an orthopedic service line. It's been very successful. It's been up for about 7 going on 8 years. We partnered with you, Joe, back about 7 or 8 years ago, and it's probably been the best thing we did at the health system level to improve patient care and to improve my quality of life as a surgeon. So the infrastructure is in place, but we have what I would call the classic model, where we meet once a month and we do all the work in one group setting like we are right here, and then we have smaller breakouts. But I think the next level, you need to tease it to more sophisticated breakouts for perioperative and outcomes management, acute care, peri-op care, and all of those kind of issues.
Yeah, and one of the areas on that box of infrastructure is the post-acute care, and let's talk. We'll get into that in a little bit more, as we go forward. Now, from a surgeon's perspective, right now you have a directorship role at the hospital, which really is having you getting paid a fair rate based upon the time you've put in. It looks like going forward with this CJR that you may go more to a co-management agreement. Talk a little bit about what you see as the advantages and maybe some disadvantages of that.
Sure. I think it remains to be at the table to make improvement for the betterment of the health system and for patient outcomes. As you know, there's going to be work that you need to do to achieve the goals, and then the benefit or the risk sharing or gain sharing portion is we're going to set targets, and then we need metrics to get to those targets. So basically, you're going to do the work, you're going to try and improve patient care, you're going to try and decrease cost, and then you're going to try and hit these metrics. And then if you hit the metrics, that's the second trigger in which physicians who are collaborating or engaged can share in the profit of the revenue.
Yeah, and I think going forward in this model, you're really going to see 2 types of relationships between orthopedic surgeons and the hospitals in this. One, would be the surgeon group truly being the collaborators under the rule of CJR. Again, I think the advantage of that, there's high risk, there's high reward potential. There's also high risk. The other part of it is that you're sort of locked in. The advantage of the co-management agreement is it allows you to really look at metrics almost on a year-to-year basis and be rewarded on that component of it.
Correct. I think the co-management's the safer route for both the health system and the surgeons. I think you could argue that you're minimizing the risk, and to a lesser extent you're minimizing the reward. But the gain is that you can set these metrics every year, and so as CCJR goes forward years 1, 2, 3, 4, and 5,
right,
we can go step in step with that. So
right,
that's a nice option for the treating practitioner.
Yep. Now, second area that we talk about, as far as keys in this bundle payment world, whether it's CJR or other programs, is when you start looking at data, you've got to begin to think like the payer. And in that, you're not only looking at your internal hospital costs, but you're looking at what the payer is paying out. Not just to the hospital, to the surgeon, all the pre-admission components, readmissions, post-acute care. Tell me what you've been doing up to this point, and how do you see that changing when you get to the bundle payment model here in a few weeks?
Sure. This is probably the most interesting aspect for a treating surgeon. So, obviously we focus on the peri-op, the piece that we're in control of, which is patient care we see in the office. We evaluate, review the x-rays, perioperative, what I call optimization. The old term was medical clearance. Right. So we can control that. And then when we partner with you back when we set up the orthopedic service line, we partnered with the health system to grab hold of the in-house piece. So that was length of stay, on-time start times, discharge planning was a piece of it, but we really were focused on the inpatient piece.
Right.
And then when you look at this slide, or if this slide pops up, the next piece that's really impressive is the post-acute care piece. Is really, it's about a third or more at times of the entire care package. And that's a piece that as a physician we used to kind of say, get PT and move on,
right,
and we were kind of done. And I think now we will be engaged in how do we drive better outcomes through that.
Yeah. Well, up until this point, until the bundle payment programs became more popular or more prevalent in the market, there really wasn't an incentive for the hospital or the surgeon, to look at that aspect of care. And this is a big opportunity.
Absolutely. And one of the things I've said to my own health system is there's a tiny disconnect between my staff trying to get someone safely ready for surgery, to do well for surgery, to do great. But my staff is not really concerned with whether I start at 7:30 on the button,
right,
or if you go home at 10 o'clock on Thursday.
Right. The third area is really having benchmark metrics, because we know that complication rates, readmissions, those drive cost. This is your national data from Hospital Compare, so your complication rate is below what we see on the national average, but yet we know these are risk adjusted, but it's difficult. You've got a difficult patient population, a little bit more rural area. Can you talk a little bit about what you're doing, that patient population, and what you're doing to minimize the risk for those patients?
Sure. I think all surgeons like to say they have the toughest practice and logistics,
patients, right,
the oldest patients, the toughest patients. But some of these new metrics give you some real-time data. So one, I'm proud that we're below the national averages, and that probably is truly an outgrowth of peri-op optimization, the term I use, and collaborating with the Accelero and the health system to do the service line. Right. The second piece, due to time constraints, we couldn't put the slide in, but we do have the government data which shows our comorbidities up at Butler. So this is a region where I practice, and so if you take standards, for example, obesity or morbid obesity, we know that's negatively impacting
right,
the patient outcomes, but we unfortunately have a 33 to 50% uptick in both obesity, which is bad enough, and morbid obesity, which is way worse, and then correlate that with sleep apnea, which is just a sidebar. Similarly, but importantly, diabetes, which surprised me, we were almost 50% higher than the national averages. So what that means is, as you saw the slide where we break it out further, we're really going to have to optimize patients. We're going to have to do a wonderful job with pre-selection, and then we're going to have to manage it from the second they walk in the physician's door all the way through the end of the episode of care.
Right, right. Yeah, it's a big difference in what you're doing now. The fourth area that I want to spend a little bit of time on is just this whole idea of care variability, because I showed slides early on looking at variability within a market. You could see that same variability within a hospital. And now with you taking on the role of a surgeon champion, leading the group in wanting to get results, now you're going to have to really have even broader discussions with your peers about care. Tell me what you've done in the past to reduce that variability, and where do you see that going forward?
Sure. About 8 years ago, we took the first steps, which was implementing nursing pathways in the background that matched the physician order sets in the foreground, which matched what I directly wanted done on the floor. And then as far as reducing variability, what we did is we showed best practices. We implemented them, to be honest, initially in very narrow networks, but as you can imagine, they were effective. Right. And so very quickly, whether it's the physician or the physician extender would rather be on the team where things are easy and smooth than harder. So that was the old technique. I think we will be more firm in this new CCJR moment where we're going to say, look, these are best practices that are accepted and established, and we are going to need you to work within these.
Right.
So I see with CCJR another drive to optimize it. I think our role will be a little more critical. I think I'll be more forceful. And when I say it that way, I just mean when we're presenting best practices.
Right.
You got to respect historical and cultural, but as we see best practices, we need to put them forth.
Right. One of the areas that, if we look at those costs that we traditionally don't look at, one is readmissions, right?
Sure.
So, again, we look at Butler's data below the national average, which is good. Some good information that, the average cost of readmissions around $17,000 for total hips, $13,000 for total knees. If you normalize that across all of the cases, what I like to look at is what a readmission kind of burden is per case, right? And here you see, nationally that's probably around $900. At Butler, I know you're coming in around $700. So, what information are you getting right now from the hospital as far as readmissions and the cost? And how do you see that needing to change in the future?
Well, I think we're doing a good job now, but I know we can do a better job. As we talked about earlier, and we had a rough flight getting here, I really think you need to go towards that win-win model. So, in other words, we know we have low readmission rates, and we know we have a low cost per readmission, so our readmission burden is a little lower than the average. That being said, that's a big piece of that pie that we all would like to be zero. Now, I don't love the term never event. I'd like to approach zero from myself and my practice, and I think that's attainable and reasonable. I think what you need here are metrics, because even if you recall about 3 years ago in my health system, we had a metric issue, but if you don't fix that, that is a reported outcome, and that's going to be a problem in the new model. So for us, if you recall, it was urinary issues that were not properly labeled, but then reported, and you can't allow that.
Yep. The last area that we want to talk about is just this concept of post-discharge care. You mentioned early on that it can be as much as a third of the total cost. What we see from our database of hospitals that we do work with is that, on average right now, about 70% of total hip and knee replacement patients across the country go home, 30% go to some other facility. Obviously we see best performers, 87, 90%. Again, it goes back to that initial slide. There will always be patients there, but, the eye-opening area for everybody now is this big difference, okay, in the cost in these three areas. And obviously, the first opportunity is how do you move the patients from skilled nursing that may not need that or shorter episodes there to home care, but I also think there's going to come a point where you can look to say what's the right amount of home care versus people just going to outpatient or some patients that may not need any therapy. Going forward, how are you as a group going to begin to look at that?
Well, we've been looking at it for about 2 or 3 years now, as you know. And one of the issues that I think for the audience to understand is there are cultural changes, as you know, meaning regions that have a high disposition to home or regions that have a high disposition to skilled rehab or home care. Right. I think when we looked at the pie chart, these numbers are eye-opening because the average practitioner surgeon certainly didn't get educated on these numbers And many people prior to these kind of talks would never know these numbers are that dramatic.
Right.
What I can tell you we're implementing right this very minute is looking at, in addition to all the care team that I have in my office, adding a true dedicated patient care coordinator.
Right.
The goal early on is for, and this is a little bit of a long answer, but the people who are not quite ready for surgery, we want the patient care coordinator to assist us, whether it's
Right.
weight loss, smoke cessation, diabetic control, lifestyle issues. Then when we get them in the wheelhouse where they've failed conservative care and are a good surgical candidate, we then want the care coordinator to help us with a home visit so we know, is this a good straight-to-home outpatient PT
Right.
like one of Mark's patients? Is this someone unusual who really needs skilled nursing, maybe 4 or 5 days, but then you need a reasonably cost skilled nursing facility who sets reasonable goals,
Right.
if they're going to be a partner in this. Similarly, who's a good candidate to go home and just do home care for 2 weeks and then straight to outpatient PT? We didn't have control of that before because, like my staff, I'm not sure anyone ever told me why I should grab control of it.
Right. Yeah, you know, the other part of that navigator too will absolutely be to follow the patient post, because it's not just a matter now of the patient coming back to your office, it's knowing what happened in that time period, because that's part of the cost.
I think this also helps with metrics like patient satisfaction, these new reporting outcomes. You know, we did that back in the 80s and 90s, then we stopped, and now they want them back. Well, you've added electronic records, you've added a lot of burden to the practitioner, and now you're saying also gather outcomes. So part of my role is I envision the care coordinator grabbing that early snapshot of where they are, grabbing the late one, and then you have reportable data.
Right. So thank you. You know, again, you know, a pleasure knowing that, you know, you've had a lot set up that positions you for success in the CJR component of it. You know, again, the concept of the infrastructure, the data, best metrics, variability, and then finally the discharge care, those will all be key. All right, so let's transition. I said at the beginning there were two main areas that we're looking at in this conversation, and again, people think about that as different. Well, there's, you know, bundle payment and there's outpatient. Well, you know, I look at it as a continuum. There are absolutely a certain percentage of patients that it makes sense for them to have outpatient joint replacement, and we're very privileged tonight to have a surgeon who has done well over 3,000 outpatient joint replacements in a hospital setting, and recently over 1,000 in an ambulatory care setting. So I'd like to turn it over to Dr. Mark Hart Span to talk about the processes that he's put in place to really make this effective for a group of patients. Dr. Hart Span.
Thank you. I'm going to speak a little bit about outpatient and what made me get into it. I started to do outpatient joints back in 2002 through my 2-incision hip experience. And in some institutions that was an easy thing to accomplish, and in other institutions that was a more difficult thing to accomplish. I found that in my institution, I ran up against a number of walls. And beginning with the easiest one to overcome was the purported lack of availability of enough physical therapists. And that extended all the way down to the kind of old concept that you shouldn't do physical therapy when a patient's in the recovery room, even though sometimes our patients at that institution spent 6 or 8 hours in the recovery room waiting for a bed. So I was able, through multiple encounters, to accomplish that and get therapy that began when the patient was neurovascularly intact. The hospital purported not to want to encourage my performing same-day discharges because they were concerned about a financial disincentive, I think particularly with the Medicare patients. And I think that really comes down to knowledge of the modifiers that they need to use to allow a same-day event. The two biggest problems are the last two. I think just a hospital is a big machine. The hospital that I first began to do this work in is over 1,000 beds. So there's this time-honored institutional resistance to changing what they're used to doing. And that's manifested most by the nursing staff. I would often have great nurses that I'd been dealing with for 20 years who would kind of whisper to a patient, you know, you don't really have to go home today, or I'm not sure why he does this. And once you do that, you uncouple the process of getting somebody home the same day. It's something that we'll discuss it as we go on, but it's something that gets set up with your initial consultation and has to be augmented throughout the process. So with respect to my ASC experience, in June of '08, I began to do true outpatient joint replacements, and that was in a freestanding unit about 3.5, 4 miles from my hospital. When this slide was prepared, we had done 803. There are now another 100 or two. I began with hip replacements because I perceived that as being the easiest or the least risky. And I went back to doing 2 incisions, which I hadn't done for some time, because they had traditionally been the most consistent patients to go home the same day. But I went back to doing many posteriors, which I've been doing for a long time now. And then after a year or two, we began to do knees. And at this point, it's about 3 to 1 or 2.5 to 1 hips to knees. And those are just standard mini quads incisions. The unit that I work in is a 3 operating room unit, and there has to be at least 2 ORs at my disposal. You have to have multiple anesthesiologists because you can't be efficient when you're waiting for the same one anesthesiologist to follow you into different rooms. In this unit, there's a full x-ray department with a PET scan on the first floor. So that's very convenient. You have a fluoroscopy unit if you need it in an emergency, femoral fracture or something like that, which we have not had yet. There's also a physical therapy unit on the top floor. So on Mondays, when I do my outpatient joints, there's a physical therapist who's basically working for the unit. So I can get my patients up 45 minutes post-op, and they will come. That therapist will return every hour or two until the point that the patients are safe and ready to go home, which is usually sometime between 3 and 5 o'clock. When we initially started this, we developed a working relationship with a blood bank. So particularly for knee replacements, I used to type and cross or have them pre-donate a unit or 2. At this point, with tranexamic acid, we haven't used blood in a number of years. And I don't even know that we have that working relationship anymore. This is the breakdown of my patients. It's a wide age range from 22 to 71 with a mean of 55, which is only 2 years younger than my in-hospital practice mean. So it's not very different. The comorbidities, certainly the sicker patients go to a hospital, but there's a wide range of comorbidities that we've done with a mean of 1.5. The surgical time is fast with a very narrow range. I'm blessed with working with the same good people all the time, from anesthesia to nursing to my assistants. So we're able to be very efficient. I think the hard point is deciding if you want to do it or not. And if you're going to do it, you want to start in your hospital where you have that cushion. So you want to make the decision, and you want to hone all of the different procedures that are required to get it done in a consistent way within the institution. What I will assure you is if you can do it in a hospital, you can do it anywhere. So this process of choosing who gets an outpatient joint replacement begins when I meet that patient. And it's really a motivational thing. If the patient is within the realm of a consistently predictable hip or knee replacement in terms of time and complexity, they're kind of directed that way. Obviously, inpatient is always offered to them, and I think a non-biased way. But there are certain patients, what I'm really referring to is there are certain specific patients that I won't offer an outpatient experience to. Somebody who right from the get-go insists on going to a nursing home or a rehab center. Those patients are out of the mix. Somebody who doesn't live in a situation that I think is safe for them to go back to. Somebody who lives truly alone. And there are patients who live alone, but I will ensure during that early conversation that they can arrange for somebody to be with them for a few days or a week. I think you need an office staff that's on the ball and understands the process. You have to give patients information, whether it's printed literature I'm showing my age with video, but a DVD, I should probably take that off this slide, office website. Whether you have a joint camp within your office or a joint coordinator like Muzzy was referring to, who kind of oversees the process, knows the answers to all the questions. And I think the thing is consistency, because if you have a patient who's wants to do it and is motivated and understands the process, and you've deemed it safe and appropriate for the process, it's still a relatively new thing. And all it takes is a sister-in-law to overhear a conversation with a nurse or someone in your office staff that can throw in enough question that they're going to go in the hospital for their surgery. You have to do a number of things within your hospital first, and it's harder in a hospital to do these things. But I think you should try them there. You have to find anesthesiologists who are willing to do something. You have to find an OR staff that's willing to think out of the box a little bit in terms of process, to streamline trays, to work more efficiently. You have to have an open mind. You have to listen to them.